and welcome to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. Each episode of the podcast will discuss some fantastic clinical cases and we'll really get down to the nuts and bolts of how we solve those tricky clinical conundrums. Each episode, I will be joined by a different guest from somewhere all over the world. This episode, I am really honoured to be joined by
Ben Lovell. Hi, I'm an acute medicine consultant working in London, where I do a lot of education and teaching.
Fantastic. Thank you so much for joining us, Ben. We're a few days before Christmas, so it's fantastic that you've made the time to do this with us. I'm Amie Burbridge. I forgot to introduce myself, or have I? I'm Amie Burbridge. I'm a consultant in acute and general medicine working in Coventry in the United Kingdom. So, Ben, I'm going to present you with a case, and I really want to see how you would work through the case, really from the beginning, thinking about history, examination, and investigations and management.
Okay, go for it.
I'm going to set the scene. It's 10 to 8 on a Tuesday evening. You are the consultant on call, and you've actually been at work since 8 a.m. that morning. So it's the end of your 12-hour shift. And what you like to do before the end of the shift is just see if there's any people who are waiting to be seen that you think you could see them, send them home quite quickly. So you don't want to hand over too many patients to the night team. It's been a very busy day and you're worried about fewer numbers of staff on at night. And actually, you just want to make sure that the department's all in good order before you finish work. So at 10 to 8, you're in the medical decisions unit and you pick up some notes of a 28-year-old female. And you see that she's had a 1-week history of shortness of breath, palpitations, a little bit of dizziness, and just not feeling right. And she can't quite pinpoint why. So you pick up the notes and you go, she's 28. You do that, you look at her sort of from the end of the room and you go, she looks really well. She's sitting there playing on a phone. She does not look like she needs to be in hospital. Okay, so you call her through and you take her into a cubicle and you start to take a history. And she's very well in herself. And you're chatting away and you're talking about what she does for work and that sort of stuff. And you're like, she doesn't seem short of breath. She's chatting away, no problem. You notice that she's not coughing. She doesn't look pale. She's actually looking very well. And you ask a few more questions. She's been short of breath for about a week. She hasn't had a cough, although she has had a little bit of central chest pain every now and then. She's also describes palpitations, but she tends to feel those at night when she's lying in bed. And she feels that her heart is racing. And then she doesn't tend to notice it during the day. She also says that she's had some episodes of dizziness. And this is normally when she's been walking upstairs, walking around the house. And actually, she started to feel this dizziness. And she actually feels that that's probably the worst symptom. So you do a brief again, you think she looks very well. You examine her, and then the routine blood tests that have already been done and requested are back. And just as you are about to go home, you say to her, just wait there. I'm just going to wait for your bloods to come back. I'm sure they're going to be absolutely fine. In fact, you know what? You don't really need to wait. I'm so convinced your bloods are going to be normal. You can go home and I'll phone you with the abnormal bloods. But then I get a phone call from the lab. And the lab say, do you have patient 0? And I say, yes, we do. I've got some abnormal blood tests for you. Okay. So they tell me that her hemoglobin is 70. Her platelet count is 22. Her U's are normal. Her liver function's normal. But it's this platelet count that they're basically phoning through. White cell counts, normal. So you've now got a 28-year-old female who looks very well with a hemoglobin of 70 and a platelet count of 22. So I panicked a little bit and really had to go back to basics. And I then had to go back into the patient, retake the history, and go back to the beginning. So what would you do in this situation?
I thought you were leading up to tell me that she's going to have a funny D-dimer result.
Ah.
They are always the results that I never wanted, but I always
Yeah.
get given, and then I have to make sense of them, and they're never normal. And I hate the D-dimer. So I was like, oh yeah, what's the D-dimer? Okay, so you're telling me that she's got bicytopenia. She's 2 lines of her bone marrow are impaired. So my first gut instinct is her bone marrow has gone wrong, and she's not making these cells. But I guess we still have to do a full assessment to make sure she's not losing or consuming platelets and hemoglobin. So am I allowed to, is it her MCV was normal or any iron stores? Do we have that at this stage in the story?
We do. Her MCV was normal at 88.2.
Okay.
Her iron was 13.
Okay.
So on the lower side of normal, really, but not grossly low.
Okay. And she presumably has not reported any blood loss from anywhere, menorrhagia, GI bleeding, or anything like this. That would explain the low HB.
Well, this was something that I hadn't asked her in the initial history. So definitely something that I reflected on and thought, oh, I really messed up there, to be honest. So she didn't complain of any GI bleeding when I asked her. She hadn't had any abdominal pain. She had, however, had a miscarriage 6 weeks prior to presenting to hospital. She'd had 3 pregnancies, and each pregnancy had ended in miscarriage within the first trimester. And these pregnancies had been over the last 2 years. So she was actively trying to conceive.
Okay, so 3 concurrent miscarriages does make me wonder about a coagulopathy. So I'd be interested to see what her coag screen was, because something like undiagnosed antiphospholipid syndrome or something similar can sometimes first present as recurrent miscarriages due to placental thrombosis. So I'll be looking for a coag screen. I think looking at the patient now, I'd be more thinking this is a hematological rather than a gastric or a gynecological problem. And I probably would say, let's get you onto a bed and let's look for any lymph nodes, and let's see if you have a big spleen, looking for any signs of hematological malignancy, any rashes that maybe she hasn't noted, petechial hemorrhages anywhere that she hasn't noted. And I would be thinking about working up from a heme point of view. So I'd like to get a blood film and looking at a coag, looking at extended blood work and examining it for any clinical signs of hematological nastiness. I guess from a clinical reasoning point of view is, once I've done that, do I send her home? I've always been a big believer of treat the patient rather than the numbers. And if a patient does not require any hospital treatment, i.e. anything intravenously or oxygen, then do we really need to put them in a hospital bed, especially considering the eternal but now very bad bed crisis in the UK? We shouldn't be using beds lightly. And also being admitted to a hospital bed is a big undertaking for the human body to go through, both physiologically and psychologically. So I think if I had a good follow-up service, for example, if I was able to examine her now, take all the blood tests that I want to take and say to her, okay, we'll see you back here tomorrow at 9 a.m. for further evaluation, for example, in my ambulatory care unit, then I still would be leaning towards sending someone like that home. And I know that not everyone will agree with me, because 70 is a low hemoglobin. But if she is not showing signs of acute anemic complications, she's not breathless, she told me, she's got no signs of heart failure. She may well have a flow murmur when you examine her, but I still wouldn't necessarily be leaping into a hospital admission and giving her 2 units of red blood cells now, although that's probably on the cards, because I want to gather more data. Does that make sense?
Yeah, absolutely. And I completely agreed with you. And that's exactly my thought process too, is she still looks really well. Her hemoglobin is 70. So yeah, that is low. But, people often do have a low hemoglobin and are able to carry on. But the platelet count of 22 was concerning. And we did a coagulation profile, which was normal. Prothrombin time, activated partial prothrombin time, again, was normal. However, somebody had ticked that box on the request form for D-dimer.
Oh no, I knew it was coming. Yes, okay.
And her D-dimer was 2.54.
Mhm.
So we've got a raised D-dimer, a low platelets and a low hemoglobin in a 28-year-old female who's had recent miscarriage, presenting with dizziness, a little bit of shortness of breath and palpitations.
Mm.
So I am very much like you. I am discharged until proven otherwise, because actually, if patients well, they are best looked at in their own home if they are well enough to go home. Something didn't sit right though. That gut instinct in me said something's not right now. I don't know what it is. It just doesn't feel right. And I didn't know what it was. So I took a history, again, nothing really significant. There was no past medical history of note. She was on medication, no family history of note. She worked full time as office work, and she'd still been going to work, no problems. She tended to spend most of her day looking at a computer, but hadn't been unable to do her work. She didn't smoke, she didn't drink any alcohol. So I examined her, and whenever I've got an individual hunted to hospital and I am unsure what's on, I like to do a full top to toe examination, trying to find anything or something that may explain the abnormal blood results that I've found. So on examination of her hands, I was looking for folded files. She got any microthrombi? Is that why she's got low platelet count? Didn't find anything. Pulse of 90 beats per minute. Absolutely fine. Blood pressure was 120/72. Normal. Looking at the face, she had slightly pale conjunctiva, which would account for the anemia, but again, nothing else significant of note. I was unable to feel any lymph nodes. On examination of the heart, I didn't find any murmurs. Apex beat was not displaced. Examination of the abdomen was soft and non-tender, and there was no organomegaly. The chest was clear. In the legs, I didn't see any peripheral edema. One of the legs wasn't tender or swollen, suggestive of a peripheral thrombus. She was overweight and she had an elevated BMI at 37. But aside from that, I could find nothing of note at all on the examination. So, any more thoughts now, Ben?
Not really. I mean, there are some really esoteric things I'm thinking of, but when she's dizzy, but she's not confused and she's not febrile, is she? And her inflammatory markers are not elevated.
So at the initial stage, we hadn't done her inflammatory markers,
Mm.
but we did add on a CRP, which was 134.
Mm.
So a C-reactive protein was 134. What's going through your head?
I'm thinking TTP, but it's very unlikely. So thrombocytopenic thrombotic purpura, but she hasn't got any purpura. She hasn't got the renal failure. She hasn't got the fever that goes with it. So I'm just trying to explain this low platelet, but I still think bone marrow is the culprit here. So she certainly needs a bone marrow examination. She's not immunoparesed because her white cell count is still normal. So the CRP could be explained by some paraneoplastic, some malignant process, undiagnosed hematological malignancy, or there could be infection somewhere. I don't think you have enough evidence to go on to do things like Dopplering her legs looking for a clot, because clinically she hasn't got one. And we know that an elevated D-dimer in isolation doesn't diagnose anything. It's only used with your preclinical, your clinical suspicion for thrombosis. So you've alluded to two sort of phenomena here. You've alluded to gut instinct, which I think is absolutely crucial. And I think that if you were just concerned about this person, you didn't know why, then admission would be a reasonable thing to do. And I don't know if that's what you went on and did.
Yeah, absolutely it was, because I didn't know what was going on. I was completely flummoxed.
I don't think I'd replace anything. I wouldn't replace platelets. I mean, you see people who've got, for example, ITP walking around with platelets of 9 or less. And as long as she's not bleeding or has an ongoing infection, I think a platelets north of 20, hers are 22, would be okay. So I wouldn't give her any platelet infusions. I wouldn't give her any blood right now, because she probably does need them down the line, but I don't want to mask or muddy the waters of diagnosis by giving her blood products at the moment. So admission for early morning hematology workup, I think, would be reasonable.
Yeah. And the D dimer of 2.54, again, is that a red herring? D dimer can be elevated for many reasons. She had a miscarriage within the last 6 weeks. So that could account for some of the elevation of the D dimer, potentially. So
2.5, and your upper limit is 0.5. So I guess in my hospital's units, that would put her D dimer at about 25,000. So that is very, very high. But as you say, not diagnostic of, it's a fibrin degradation product. So she's breaking down clot, but it doesn't necessarily mean she has a VTE, a venous thromboembolism anywhere that needs acting on.
So we've now got this lady with a hemoglobin of 70, platelet count of 22. Any other investigations you'd like to do for the low platelet count, for the thrombocytopenia?
Well, I probably would send bloods for my usual hematology workup, so looking at B12 macroglobulin and LDH to see if there's any hemolysis. And I probably would send an autoimmune screen as well from a hemoglobin point of view. From a low platelet point of view, I'm thinking about consumption. So I'm thinking about immune-mediated consumption. So you could send a screen for ITP, immune thrombocytopenic purpura. When she was, she's not received any anticoagulation, has she?
No.
No, she's not had any low molecular heparin or anything like that. So it's not going to be heparin induced. So I think you can still do an immune screen for thrombocytopenia at this point. Okay.
So you mentioned LDH. So she did have an LDH, lactic dehydrogenase, which was 1,418, and a normal range there is 200 to 500. So significantly high. She also had a reticulocyte count done, which was 372. Normal range in our hospital was 25 to 80. Haptoglobin, less than 0.1, which was very low.
So this is having a sort of a consumptive sort of flavour to it now. So yeah, we need to get an immune workup, don't we? So DAT and Coombs test and all that sort of thing, looking for. Although, yeah, usually you see this with someone who's got an immune reaction against hemoglobin. It's unusual to have it against both hemoglobin and platelets, but I think we need to work to rule it out.
Direct Coombs test was negative. And she had a blood film. And the blood film showed large numbers of schistocytes, so fragmented red cells, and also clumping of the platelets.
Okay.
At this point, I have to say I still, again, didn't really know what was going on, because I thought the same as you. There is consumptive going on. Her reticulocytes are very high, so she's got lots of immature red cells. Her LDH is very, very high, which indicates breakdown of cells, or lactic acidosis it could indicate, or some form of ischemia. So we did a troponin. Troponin was slightly elevated, but again, nothing significant. There was just so many things going on. I couldn't put the puzzle together. So I admitted her. I had no choice really to admit her. So I've now got somebody with schistocytes on the blood film, which is indicative of microangiopathic hemolytic anemia. So again, huge amounts going on in what looks like a very, very well individual. So something that you mentioned earlier that you quickly discounted.
Oh, TTP.
TTP, thrombotic thrombocytopenic purpura.
Oh, gosh, that is rare.
So hadn't really thought of this, and then when you sort of try and put all the picture together and you look at the blood tests, and I was like, okay, well, that would actually go with TTP, but the patient doesn't fit with TTP.
Yeah,
she's so well. And that classic pentad that you learned at medical school.
I'm just drawing it out now. Just writing it down. Yes, okay. I've got coagulopathy, renal failure, low platelet, anemia, and fever.
Yeah. And the other one is neurological abnormalities.
Oh, so,
which she didn't have.
Yeah. And these cells, they weren't confusion, were they? They weren't delirium. No. Oh, okay.
No, I mean, I didn't see that, but that doesn't mean that wasn't what she was like when she was having these dizzy episodes that she was describing, because I didn't get a collateral history. She wasn't in hospital with anybody. So I have to say, I was shocked. And then I got a phone call from the haematologist on call, who must have looked at the blood film and said, "You've got this patient in the medical decisions unit. I've looked at the blood film. They've got schistocytes, low platelet count, the raised D-dimer, the raised LDH. This is thrombotic, thrombocytopenic purpura until proven otherwise."
Okay.
So the examination was normal. She had no purpura. Her renal function was normal, but the diagnosis at this stage was still thrombotic thrombocytopenic purpura until proven otherwise. Thrombotic thrombocytopenic purpura is obviously a very, very fatal condition if untreated. And therefore, the diagnosis was TTP until proven otherwise. And we needed to admit that, and we needed to treat ASAP.
With
And we
steroids or?
So the treatment for TTP hasn't really changed in the last sort of 10 years. And there is a guideline, which is very, very good, actually, done by the Society of Haematology. And that was actually written in 2012. That's the only guideline in the whole world on how you manage TTP. And that is how all of our European countries and America actually use this guideline. And it hasn't changed. Apart from the addition of caplacizumab over the last couple of years as a treatment, I'm going to talk about treatment in a little while and how we actually manage TTP. Have you seen TTP, Ben? Is it something that you are
Yes,
treated in the
only
past?
because I did a rotation in my training in intensive care where they were a regional TTP centre. So have I ever
Okay.
made a diagnosis of TTP myself? No, because I have looked for it before, and there's a blood test I remember called the Adams TS13, but I've never made a diagnosis just in my general unselected acute take before, so no.
Yeah, and I have to say, this is the first time I'd seen TTP as an acute admission. And I always thought when I was training that if I saw TTP, the patient would be very, very, very unwell or look very unwell. And it was very disconcerting that the patient looked so well. And I hadn't even thought about this diagnosis because she looked so well. And interestingly, her clinical course, she did deteriorate and became more unwell over the couple of days that she was in hospital. So we actually probably got her very early on in the diagnostic process before she became very, very poorly.
Yeah.
So I'm going to talk to you a little bit about what thrombotic thrombocytopenic purpura is and what causes it, and a little bit about the physiology behind TTP, because it's actually really, really interesting. And it's sort of one of those things that you read about and I memorize it and then I forget it sort of the next few days. So I thought it'd be good to just recap before we go over the investigations and the management plan. I'm going to focus on acquired TTP. There are many, many types of TTP. It can be congenital, it can be associated with HIV, with pregnancy, with medications such as quinine and estrogen-containing medications. But the main one today I'm going to look at is acquired thrombotic thrombocytopenic purpura. Now, what normally happens when we normally hemostase is you get some form of trauma. And whenever you get trauma within the endothelium, you get constriction of the blood vessels. And what happens is the endothelial lining is exposed and you're triggering off lots of chemokines, cytokines, endothelins, and platelets rush to the area. And they go like little homing pigeons. And the platelets run to where the damaged endothelium is and they form this platelet plug. This platelet formation and this plug formation is activated by von Willebrand's factor. And this is the key driver of TTP. Now, von Willebrand's factor is a large adhesive glycoprotein. It's produced by the endothelial cells and also by megakaryocytes. It's cleaved into smaller forms of von Willebrand's factor by Adams TS13, and that was what you previously mentioned. Yeah. Now, Adam TS13 stands for a disintegrin and metalloprotease with a thrombosporin type 1 motif member 13. So I can definitely understand why they've shortened that to ADAM TS13 because it doesn't roll off the tongue. And what happens is it's cleaved into smaller amounts by this ADAM's TS13, but in TTP that's acquired, you get antibodies to ADAM's TS13, so the von Willebrand's factor stays very, very large. So you've got these huge multiples of von Willebrand's factor running around your blood vessels, and it sort of gets stuck in the blood vessels and makes the blood vessels, as well as being vasoconstricted, very difficult for blood to get through. So as the blood goes through, it shears and it breaks off. So your red blood cells are going through these narrow blood vessels, normally in the microvasculature. So you tend to find those in the brain and in the kidneys. And that's why in TTP, you get your confusion and also your renal failure. So you get your schistocytes on your blood film. You're getting your low platelets because the platelets are all clumping. Because you've got so much of these large von Willebrand factors, you've got these huge clumps of platelets everywhere. And that's exactly what's happening in TTP, is it's blocking your blood vessels. And the more and more von Willebrand factor you get released, the more platelets you get aggregated. The platelets change shape to create more clots, and you just get more and more clots being produced. This activates the coagulation cascade, where your prothrombin gets converted to thrombin by factor 10A, your fibrinogen gets converted to fibrin, and you get your fibrin mesh around this clot. And that is ultimately what's happening in TTP. Does that make sense?
Yes, it does. Beautifully explained.
It's one of those things that I think when you understand it, the pathophysiology, it makes TTP sort of more easy to understand why it happens, but it is quite difficult sometimes to get your head around, definitely. So investigations then for TTP. We're going to get low platelet count because they're all clumping together. We're going to get low hemoglobin because we've got this microangiopathic hemolytic anemia. On our blood film, we've got schistocytes, which are our fragmented red cells. We've got raised reticulocytes, which are our immature red cells. We've got decreased haptoglobins. Haptoglobin binds to free hemoglobin. Because we've got so much free hemoglobin, because it's all been released, our haptoglobin is very low, which it was in our case. Your direct Coombs test is negative. Our lactate dehydrogenase is high because she's hemolyzing. And our coagulation cascade, our coagulation profile is normal. PT, APTT, and fibrinogen. D-dimer is often high, and even now they're still not entirely sure why D-dimer is actually elevated in all of these cases. And also, we then send off and do an ADAMS TS13 profile. That's really important because that will tell you whether you've got an acquired TTP, and it also helps when you think about how you treat it. So, treatment-wise, you mentioned steroids. Absolutely. Steroids is how we treat it. High dose methylprednisolone or sort of higher dose prednisolone. Plasma exchange is, however, the key treatment. And this is because it takes out these huge numbers of platelet molecules that are running around, and it also repletes the normal ADAMS TS13 levels. You can also use rituximab. You may need red cell transfusion, folic acid, and also never forget thromboprophylaxis if and when your platelet count becomes greater than 50 times 10 to the 9 per litre, because these patients will still be at risk of blood clotting. Now, over the last few years, we have now got another medication called capiosizumab, which blocks the interaction of your von Willebrand factor and platelets. And that's now been approved for use in patients with TTP. Again, all of this treatment has to be given by specialised haematologists. So it's not something that I was using in MDU on a Tuesday evening, I have to say. Sure. But she was taken to haematology that night and plasma exchange that night. Wow. Which was, incredible for the patient that she got treated so quickly. Still astonished that a patient looking so well was so poorly.
Well, I guess, I didn't know that I thought you had to look sick to have it. There is, that it could be a person sitting in front of you who looks well, whatever well means by our internal sort of senses, who can still have this potentially fatal diagnosis. So I think that's a useful learning point there.
I completely agree. From a learning perspective, this case taught me a lot. I think in acute medicine and internal medicine, we do rely a lot on our gut instincts. And when we're very, very, very busy and we've got huge numbers of patients to see, if a patient looks well, their observations are normal, we tend to think, okay, actually, they can go home. And we can follow them up maybe in clinic if they need it. So this really taught me a lesson of actually, well, patients can be very unwell. She did have abnormal blood tests with a low platelet count of 22, but even then I did still consider sending her home. So I did, a good learning point from this is, well, patients can be very unwell. And that sort of really made me think a lot about my thought processes and how I make decisions.
After this case, did your threshold for admission and for changing cases change for a while?
Yes.
Because I think that's something that's really common, and it's certainly happened to me. And, they call it recent case bias and theory. But when you have something like this, all of a sudden you become very risk averse for a while, and everyone gets admitted. And then you sort of go gently back to your baseline because you see that most people do not come to harm. Is that what happened to you?
Yes. So, first of all, I was like, why did I pick up this case at 10 to 8 on a Tuesday evening, 10 minutes before I was going to go home?
Yeah.
I'm glad I did. And I learned so much from this. I had that typical, like you describe, hindsight bias where also everybody had TTP, which clearly they didn't, but it was that diagnosis that was at the forefront of my mind in every patient I saw with a slightly low platelet count and low hemoglobin. I haven't seen another case of TTP since. But I also did think, okay, so actually my huge number of discharges in well-looking patients, how many of these were really unwell? How many things have I missed? And I really started to think about a lot of the cases I'd seen and gone, my word. And also, I rely quite heavily on my gut instinct, and it was wrong initially in this case because I thought she looked well. And it was only until I got the bloods and started to question it that I thought, actually, I need to keep her in. Challenging case.
Gut instinct. The thing about it is it guides us the right direction the most of the time. But
exactly.
It's not a sensitive nor specific test to apply when you see 20 plus patients a day. But most of the time it will keep you right, but every now and again it'll be wrong, and it's difficult to know how far you should take it. So I would say that gut instinct should be part of your assessment when you're reducing all the available information. Look at the patient, look at the bloods, look at the history, then look at your gut, and then make a call based on that, rather than being the only thing. That's the only thing I could think of to advise, because a lot of trainees, young internists and registrars, they say the thing they fear most about being a consultant is knowing who to send home, and they find that really challenging. And I say, well, I get it wrong sometimes, but I part of my assessment is gut feeling, and you get a gut feeling, which I think is called gut feeling in every language. It's a really interesting linguistic quirk. Everyone refers it as gut or intestinal or visceral, but it's something that you put your hand on your stomach when you're thinking about it, as if that's where it's coming from. And it's something that you get after you've seen many hundreds and thousands of patients. That's how you earn your gut. But you have to be aware that it is not 100% effective.
And it's really interesting that when we start, I think, as in training, we rely very, very heavily on history, examination, and investigations. We put so much focus on investigations, but actually, like you rightly say, we're taking information and making our decisions from huge numbers of factors. So the patient, the history, examination, our gut instinct, those around us, our previous experiences, our previous cognitive biases. And I think it's being aware that actually we're utilizing all of those.
Yeah, I often say when the doctors present cases to me, at the end of the case, I'll go, okay, what do you think? What's your gut? You know, I try and get them to develop it, and sometimes they look a bit surprised, like, well, I think they're fine, or I think this could be functional, or something like that.
Yeah.
But I'm interested in knowing how they're working on their own guts, which is really just the voice of your professional experience talking to you consciously. That's what we're talking about here.
Absolutely. And it's what I found very interesting about this case is your gut instinct can be wrong.
Yeah.
And I certainly learned and reflected a lot about that, because I probably did rely too heavily on my gut instinct, actually, just because I've developed it over time. We work in a rapid turnover specialty where we're seeing huge numbers of patients, and actually to make very quick decisions throughout the course of a day, sometimes you do need to rely on other things.
Yeah.
So interesting case. The patient was absolutely fine. So she was in hospital for a few weeks. She was plasma exchanged. She had her steroids, and following her up, she hasn't had any further relapses of TTP, because when you've had one episode, you can get further episodes.
Okay.
And she hasn't had any complications of TTP either, which sometimes people can see, such as renal failure. Some patients may have myocardial infarction, stroke. She hasn't had any of those.
Okay.
So she was actually really lucky in that. So some good learning points I think we've talked about there, Ben.
Thank you for sharing.
Any final thoughts?
No, I don't think so. I think that's an interesting conversation. I think it just demands a sort of awareness about your own unconscious bias and thinking. And then it may be overruling it sometimes. But it's
yes. And also, we don't, as physicians, we don't have to know everything about every diagnosis, because we can't.
Oh, yeah.
But I think what we need to be aware of is that actually taking a history examination and looking at the investigations, recognizing that they're abnormal and something's not right, but we don't necessarily have to make the diagnosis. We just have to know what the right thing to do at the time is.
Yeah. Keep your patient safe, even if you don't know. Absolutely.
Yeah. Fab. Thank you so much for joining us today, Ben. I think we certainly covered some interesting discussion points there, and also some an interesting case as well, and how we manage TTP. So massive thank you to everybody who's listening out there. If you want to get in touch, you can email me at amy@ephamacademy.org or tweet me at Amy Burbridge. Thanks for listening.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.